Everybody. Good afternoon, everybody. You have to start with a smile. Give me a smile, please. 1, 2, 3. Yes. Now we are okay. We can get started. Hello. About a few, maybe how many days back? A week and a half back, we had the International Nurses Day. Arun, did you by any chance see a Facebook posting that I had made on that day? Greeting to nurses? No, you don't have to look for it now. But I'll send it to you. I would like to you to send it to everybody.
Okay.
Because I was addressing all nurses. And I was thinking of some nurses, exceptional nurses. And I, in that post, talked about 3 nurses that I remembered all of a sudden. Only one was from my team because other 2 were long back, old history. But why am I mentioning that now? For one thing, I want you to understand how much I appreciate the nursing profession. Secondly, I also want to tell you that when I thought about exceptionally good nurses and exceptionally good doctors, the pictures that come before my mind are all people because of their compassion. I realized that while their knowledge is very important, that was not what I was admiring them for. And here today, we are talking about a subject where your humanity and compassion will be very much needed. The previous session also, I started by, at one of the sessions at least, I started by bringing myself up as your patient. I am doing it again. Someday I'll be dying and you will be caring for me. And I wanted you to think of my needs at that time. Not only for both my vitals or skin or hygiene, but also about me as a person. With that introduction, ladies and gentlemen, I am going straight to the presentation. And I'll start with this question. What's the primary duty of care of the healthcare provider? And this is from an ICMR document. If anybody thinks otherwise, you must correct me. This is what the Indian Council of Medical Research has laid down for nurses, for doctors, for social workers, physiotherapists, pharmacists, everybody, for healthcare providers. The primary duty of care is to mitigate suffering. Mitigation is both by prevention and treatment. Primary duty is to cure sometimes, because after all, only about 1/3 of all diseases are amenable to cure. Relieve often, relieve any discomfort, and to comfort always. And note this last sentence by ICMR. There exist no exceptions to this rule. It is not as if this is important only in some cases. It's always important. With that, I'll first talk about a few principles of medical ethics and then go on to end-of-life care, where the two will have to be considered together. These are the 4 fundamental principles of medical ethics. Have you studied this in your nursing course? Who do I see in front of me? Dikshita, Do you remember ethics being taught? The same 4 things? Asmita? Yes. The first is autonomy. If I am your patient, my right over myself. That is the most important thing. My right over myself. You are the nurse, you have the degree, you are wearing the hospital uniform, or you are wearing scrubs. You have the whole institution behind your back, and that gives you power. But you still have to acknowledge my right over myself. This is the only part of this whole universe where I have power over. That is today. Tomorrow I will not have power. I hope you will still acknowledge my right over myself. When you are in a position of power and I am weak. And what do you understand by beneficence? Anybody? Either speak up or put it in the chat box. Somebody? Pinky? Parvati?
Too good to the patient.
I can't hear you. What does beneficence mean? It's not a difficult question. It's almost what the word means. Somebody tell me, what is beneficence?
To do good.
Doing good. Yes, yes. So many people put it up right. Arun, are you there?
Yes, sir.
When I put it on slideshow, it's not easy for me to see the chats.
Okay.
So when I ask a question and people are responding by chat, please read it out to me. Thank you very much.
Okay, sir, sure.
This is autonomy. Each individual is master of himself or herself. No one has more right on the person than the person himself or herself. But beneficence is doing good. Non-malfeasance? What is non-malfeasance?
Do not harm.
harm to others, sir.
Not doing harm. Very good. And we'll briefly talk about justice or distributive justice. So we are coming back to autonomy. I am very ill. I am in my last month of life. You are coming to give mouth care. I'm saying, I don't know that I'm very tired. Stop all this. What will you do? Jobi, Madhavi, Harishankar, Asha, Purnamaya, what will you do? I am being difficult.
Sir, some more answers in chat, sir. That Purnamaya says not doing harm, and Diana says no to judge him with what he said. Continue to be gentle with him.
Okay, very good. Diana, thank you. Purnamaya's answer was about the other question, non-malfeasance, not about this question. Diana, so yes, thank you for being gentle with me. Harishankar, but I have a question to Diana. So Diana, that means you will just go away?
No, I'll
Yes.
stay with the patient.
Diana, you
Yes,
and
sir.
I agree with you. I agree with Harishankar. I agree with Parvati Sanda. But let me tell you, if I were that nurse, what I would do? I shall say, of course, Uncle, I don't want to do anything that you do not like. But then I'll May I sit here for a moment? I'll sit down. Uncle, you must be very tired to say you don't want it now. I'll wait for an answer. Are you very tired, uncle? I may ask again. I may say yes. So, uncle, if you insist, I can come back later. But let me tell you, even if you are tired, this is very important. Because especially when you are very weak, infections can happen easily and you will have throat pain and difficulty to swallow. Uncle, this is going to take only 3 minutes. Will you allow me to do it? No. If I say no, I would like you to go back.
Okay, sir.
After saying, uncle, that's okay, uncle, but we have to do it. I'll come back later when you are feeling better. And see here, what are we doing? You are still respecting my autonomy, but combining it with beneficence. Because not giving me mouth care will not be giving me beneficence. It may actually do me harm. So that's how we combine it. Autonomy is the first principle. You go by it, and then you explain, as Harishankar said, demonstrate, explain, do all that. Okay, I mean, what am I saying? Whether it's a doctor or nurse, the strategy is to remember that both are important, and respecting autonomy and walking away may turn out to be doing me harm. I know that what I'm saying may not be easy to do. If you're in a very busy hospital with so many patients, you can't come back. All that I accept. There may be exceptional situation where you may even decide not to give mouth care for 1 day. But if I have a family member with me, you may tell them, look, the place is so busy. I won't be able to come back for this later. Will you please do this for me just for today? And you may engage the family member in doing it. So these 4 are all important. The 4th, justice, is about distributive justice. Just because I am being difficult, if you give me a lot of time, you will be denying other patients of care. I said, if you are very in a place with 25 patients nearing with seriously ill or 50, and some of you work in government hospitals where there may be as many as 80 patients to a ward. So while I say that you respect autonomy, do good, don't do harm, okay, all right. But you have to combine with fair allocation of available resources, which includes your time. My time, your time. All this will have to be combined. And you cannot always do everything that the patient wants. That also let us accept. Autonomy doesn't mean that you will do everything that the person asks you to. It may not be possible. The important thing is not to snap at them, not to get angry, even if they behave angrily. And I know that nurses face anger more than doctors, because the doctor will go away. And next time you go there, you get snapped at. These are realities of life. But what I'm saying is, you may not do everything that I ask you to do, but you will make sure that just because I quarrel, somebody else is not denied care. But you will also make sure that because I am quarreling, you will still give me care. Somebody, I think, who was it, mentioned not being judgmental. I may be a quarrelsome person. That doesn't mean that you give me less care. Whereas, okay, I am actually explaining to you what I try to practice. If some patient is very nasty, there are people like that, always quarreling, angry, it upsets me. But I will try not to get angry, and I'll tell myself, listen, if this person is always behaving so badly to others, Manisha, lovely one, think, if this person is behaving so badly to others, is it not likely that many others also will behave badly to him or her? So I will tell myself, look, Rajagopal, here is somebody, for some reason, he is quarrelsome, he is insulting to people, and therefore he will get less kindness from others. He will receive less compassion from others. That makes my job all the more important. I will tell myself, Rajagopal, here is a man who, through the remainder of his life, will get less care and less compassion. And therefore, I have to give him compassion because there may not be many other people to give it to him. Makes my responsibility even more. Well, justice is about fair. If any of you are working with COVID patients, if you are facing the most violent form of this, having to decide between who to give a ventilator to. We can only try to be fair. We may not always be able to distribute everything equally. And here are a few things which in your classes in nursing on ethics may not have come up or may have. These are not like the 4 internationally accepted ethical obligations, but I believe these are important. Compassion. Anybody coming into healthcare without compassion is a problem. I know it happens. Many people take up medicine because they got admission after the entrance, because their family wants them to, because they think it is a good source of earning money. Many people come to nursing because they think the family is pressurizing them, or because they want to go abroad and make money. So many reasons. But the only thing is we should not allow the compassion in ourselves to die. And some of you who are intrinsically compassionate have the responsibility to be even more compassionate because others may not be compassionate. Secondly, who else do I see? Is it Ramaji or Ramaji? Vijaya? What's the name? And Sinle King? Am I pronouncing the name correct? So,
Yes, sir.
Ramaji or
Ramaji
Ramaji?
Vijaya.
Ramaji.
Ramaji Vijaya.
Vijaya. Okay, Vijaya is easier. Vijaya and Sinle. I don't know you. Your video is off. I am not even seeing your face. But I have respect for you. You know why? Because I don't have to know you. There is something in you that I do not have. Some ability, some quality. Maybe you have gone through so many difficulties in your own lives that you are a stronger person than I. Maybe genetically you are a stronger person. Maybe you sing, maybe you draw, maybe you dance. I don't know what that is. But I know that everybody, this is not only about Vijaya and Sinle. This is about everybody listening to me. I am telling each one of you that I have respect for you because as a human being, you are likely to have something that I do not have. That gives me the responsibility to be respectful to others. And when I see the poor villagers coming from illiterate villagers coming in rags, I know that they are 10 times stronger people than I because they have gone through so many difficulties, while I have had a very soft life. Respect is something that you build, and this is not only important for palliative care or for healthcare or for nursing. It's important in everyday life. When you remember, when you are convinced that others have something above you, and you learn to respect others, you treat people with respect, even when you have a difference of opinion, and your personal relationships improve. Your relation with your spouse improves because all of a sudden, okay, I've been always looking at his faults, and I've always been complaining about her faults. Instead of that, you start appreciating the positives. Respect is important for human relations. If you want to establish a good relationship with your patient so that you can help that person, you have to treat the person with respect. If you don't give respect and go, hey, how many times have I told you to keep this place clean? What is this? Why didn't you clean up? If you start like that, sorry, sister, okay, sister, and I'll shut up. I won't open my heart to you. You will lose the opportunity to help. And in the chat box, that was also mentioned, being non-judgmental. I am not a judge, you are not a judge. We are not the ones to decide whether somebody is a good person or a bad person. Whatever their behavior is, we are here to give them the best of care. And we will not offend anybody's dignity. They are weak, we are strong. But it's important that we treat them with dignity. Any comment about things so far? Comments or questions about anything that I have said so far? Arun, please help if there are chat comments, or you unmute and speak, anybody.
Yes, sir. Actually, sir, only one comment came from Harishankar, that is accepting the behavior of people.
Sorry?
Accepting the behavior of people.
Yes, behavior also. Accepting the behavior of people. Who said that?
That's Harishankar.
Harishankar, I totally agree. Accepting not only the behavior, accepting people as they are.
Sir, one more comment from that Sister Diana. We have to show more grace.
We have to show more grace to whom? Especially to the person with who is behaving not so well, who is quarrelsome. That I already. Yes, thank you, Diana. Thank you, Harishankar. So, I have mentioned the 4 fundamental internationally accepted principles of medical ethics. In addition, I have added 4 more on my own. And with that, we are going to talk about end-of-life care, and particularly bringing in ethical considerations as part of care, part of end-of-life care, combining the two. Okay. But let me start with a question to you. You know that human mortality is 100%, right? You know that not only I, but you also will die someday. Not a comfortable thought, right? My first question is this. Are you able to think about your own death? Arun, will you do the poll? See how many people are able to think about your own death.
Yes, sir. Yes, sir. Will do.
Oh, the third one, I meant not sure. Sorry, it came up as no sure. Not sure.
We kindly request everyone to attend this poll and choose the most
It's okay. We will not know who is answering. Anybody can answer. We will not know what answer is given by whom.
that is an anonymous poll only. We will not record any of your personal details or something. You can answer anyone.
I don't know what's the total number of participants.
Sir, 36, sir.
Okay. Let people think for a minute. Only a few people have responded so far. Not even 1/3 of people have responded so far. Okay, only 1/3 of people have responded so far, but we cannot wait forever. No, half the people have responded. But the next poll will come soon. Everybody, please respond. Okay, 2/3 of people are able to think about your own death. 20% are not able to, and 13% are not sure. To the people who are able to think about your own death, let me tell you that it's a strength. For those who are not able to think about it, and those who the 1/3 of people who are not able to think about it or not sure, I want you to think about it again. Because unless you are able to think about your own mortality, it's not easy to help people who are dying, to understand them, to see things from their point of view. We should be able to deal with our own mortality. When I say our own mortality, it means ourselves and our loved ones. It's a great strength to be able to think about it. Say 2 generations back, it was natural. Everybody grew up in extended families and death was all around us. It was easy. But today, as families are becoming nuclear, this is becoming harder. And in personal life also, I am sure you will have to confront death in the family, grandparents, uncles, aunts, or even parents. And you will have to deal with that. So I'm just saying, those who are unable to think about it, maybe need to think more and bring yourself to think about it at some point of time. Today, I will not force you. Today, I'm going to talk to the 67% of people who are able to think about it. To them, I am asking my next question. If you get an incurable disease and you are coming to the end of your life, would you like your doctors to try to prolong your life even of poor quality? Typical example is advanced incurable cancer. If you take more chemotherapy, your life may be extended by 3 months more. But then you will have to bear with the side effects and hospitalization. Similarly, even in COVID, success rate with ventilator we know is poor. And I'm not talking about oxygenate therapy. For people going on ventilator, success rate is only less than 13%. That means several days of agony. So this can happen with cancer, any disease. So do you want your doctors, you want to live longer, a little more? Or do you want, that's okay, when death comes, let it. I will not take this chemotherapy. I will not go on a ventilator. I want to stay with my family. So you have 2 choices. The question is, do you want your life prolonged if that life is a poor quality? Is there a poll on this?
Yes, sir.
Yes or no? Simple. No, this is the previous question. Okay. Okay, I asked only 67% of people to vote, only those who are able to think about their own death. So this is not a bad number. No, there is no right and wrong answer here, you see. For those who have decided, it's okay. Side effects are I'll accept, so long as I can live for a bit longer. Maybe the commonest reason I hear is, I want to see my daughter married. I want to be there for my son's wedding. Or my children are small. I want to be alive for them as long as possible. So here there's no right or wrong answer, but this is fairly typical. The majority of healthcare professionals will say, I do not want that extension of life of a few months or weeks with poor quality of life. When the time comes, I will go. So what should you do? What should we do as healthcare professionals? Me as a doctor and you as a nurse together. What I'm saying is, if there is no absolute right or wrong here, and we will have to go by what the person wishes. Remember, it's a matter of autonomy. One of my own closest friends and colleagues and classmates is now struggling with this choice. Her family wants her to stay alive a bit longer, want her to have chemotherapy. And she is saying, I don't want it. And what's the point of living for 3 more months at my age if I am going to be suffering? Let me stay with you here. I am reasonably comfortable. I'll stay comfortable. Okay, I have a little bit of breathlessness, but those medicines are there. I'll stay here. So here, what am I saying? I am saying that in the end of life care, what matters most is what people want. Autonomy is fundamentally important. And just as the majority of people here decided not to have the misery of interventions just for a small stretch of prolongation of life. This is not the same case as chemotherapy in a curable illness. There the answers might be different. But here in an incurable, time-limited situation. So I'll bring you back to what I mentioned in the beginning. The Indian Council of Medical Research stipulation, we have to remember that our primary duty of care is to mitigate suffering, to cure sometimes, to relieve often, and to comfort always. There exists no exception to this rule. This is always correct. If they opt for chemotherapy, relieve their symptoms as much as possible. If, as my friend said, she doesn't want chemotherapy, I still will go along with that and keep her as comfortable as possible. So this is, remember, this is what we want. Mitigate suffering, cure sometimes, relieve often, comfort always. That means your nursing care and my medical care now has to be focused on quality of life. Once we decide that the person has chosen to accept the end of life care and is choosing for comfort care, we should concentrate on making the person comfortable. Does everybody agree with that, or do some people have some problem reconciling to that thought? Everybody okay? So our objective is well-being of the patient. Secondly, well-being of the family. And we may not always make end of life beautiful, but we can try. This picture of our Dr. Amrita sitting with a patient was taken 2 weeks before that woman died. The fact that she could laugh and smile, she is on morphine and her pain is relieved, her breathlessness is better. And that is the essence of good care, quality of life, well-being, not only the patient, but also the family. For my classmate and friends, just agreeing with her without giving attention to the family is also not right, because the family members also deserve attention. I cannot compromise on her well-being. That's primarily it. But then I must talk to the family and help them to come to a state of understanding. The better you know the family, the better your care will be. If this is your patient and you are lavishing your care and affection and compassion on this man, but his one wish is to see this child again, he is reluctant to ask. His son and daughter-in-law are not very happy about bringing the child because they don't want to see the child with all his misery and agony and breathlessness. What will happen to my child? Will the child be worried and suffering? Is their question. My responsibility and your responsibility then is to understand him first, because he wants that final kiss from the child is the one thing that he wants now. Maybe we will sit with them, try to hear the point of view, not even to explain to them. Maybe when in the evening, when they come for their visit, you will take them away, sit with them for a minute and said that, I know what's happening, that he wants to see your child, but understandably you are a bit reluctant to bring the child. And they will say, yes, this is my child. It's a very sensitive baby. He's never seen things like this. And you will understand and you will acknowledge, yes, like any parent will worry about the child's well-being. But from our experience, let us tell you, the child may be worried, but this will be good experience for the child in life to accept the negatives also. And someday the child will thank you for getting that final hug from the grandfather. They may cry together, let them. But you will be able to support the child, that you will be able to support the family. If you want more time to think about it, do think, but let us talk about it again. That's what I would do. Getting to know the person and the family is very important. This man may have quarrel with his one son, and his most important wish now is to make up with him and get back into a good relationship. That's vitally important. So here is a sort of pathway that you can go by. How do you come to the conclusion that this man may be dying? One, you get the feeling. You're all experienced nurses. You know what happens. He becomes slowly drowsy or a bit delirious. The limbs are going cold, etc., etc. When you get the feeling that the team, not only you as a person, feels like this man looks like dying, and if he is two of these apply, bedbound, semi-comatose, only able to take sips of fluids, no longer able to take tablets, you will of course exclude correctable factors. This may be because he has thrush, which has to be treated. But if there are no correctable factors and these things happen, you suspect that the person may be dying. But you can never be sure. You sometimes think the man is dying, and next day he sits up and has his aloo paratha. That may also happen. That is okay. But when you suspect, you start observing. And you start trying to make the person as comfortable as possible and help the family also. Generally, when new nursing staff joins our units, I don't know, is any of our team members in the group participants?
No, sir.
Hmm?
No,
Nobody is staying.
Nobody said, sir.
Okay, generally, when new nurses come, and sometimes I ring up and at night and ask, hey, how is so and so? If they are new to this place, they will be say his pulse rate is 82, BP is 110/80, and his temperature is 99.8, etc., etc., etc. They will give the vital parameters. But 2 months after they are with us, if I ask them, they will say he is reasonably comfortable. He was having a little pain in the afternoon. We gave an extra dose of morphine. Now he is resting. He had some milk and bread. He said he doesn't want rice tonight. These are the things that experienced palliative care people will be saying. Because now, how is she becomes more important than what's the BP. And as an example, let me bring up this position change and skin care. Till now, you have been doing position change 2 hours. Maybe now you will put in a pressure relieving mattress. And if she is sleeping, maybe you will postpone the position change by another 2 hours. Because comfort, we still do not want a bed sore, pressure sore even on the last 2 days, true. But comfort and well-being are matched. And some of the things that you should think about, and maybe you should go to the doctor and say, doctor, she is still being given some statins. Does she need to? It's difficult for her to swallow this. And her BP is only 100/70. Should she still have the antihypertensive medication? So maybe, and what's the point of doing serum sodium on the last 2 days? We poke all those needles in as if that will make a difference. So at some point, unnecessary medicines you may stop, and routine blood checks you may stop. And if the person is dependent on an intravenous line, as far as possible, I wouldn't want it. Intravenous lines, especially towards the end of life, cause thrombophlebitis easily causes another source of pain. After 1 week, all 4 limbs are in pain. Can we give medicine subcutaneously or rectally, even if they cannot swallow? And eventually, you may find that I seem to be unconscious. I am not responding. But I want you to talk to me still. I may not be able to react. I may look as if I am unconscious. How do you know whether I am able to listen? Talk to me. Sit down beside me. Say, uncle, you seem to be very ill. Can I do anything to help you? You know I can't answer, but you are still conveying to me that you still care for me. That's important to me. Uncle, you are when you are sleeping, your son and the daughter-in-law came. They are waiting outside. I am going to bring them in. Just talk to them. What do we lose? Keep communicating even if the person is apparently unconscious, and give a thought to the family. Do they understand what's happening? Should we have a conversation with them? Is that your job, nurses? Is that nursing? Yes, it is indeed, I would say. Doctors and nurses shouldn't be medical machines and nursing machines. We also need to be human beings. Communication is our job. Psychosocial support also is our job. And especially if there are women, children. This happens important even in your own families. If a grandparent is seriously ill, always communicate with children, explain to them what's happening, because otherwise they will live with these huge fears in them. Oh, my friend said my grandfather is dying. Will my father also die? Will my mother also die? Oh, who will look after me if they die? These are the chain of thoughts that they may have. Reassurance is very important after giving them the truth. And if there are religious rites that are important to the family, even in your hospital, facilitate it. And as far as possible, near the end of life, encourage the family's presence. If the family wants to, you can't force them, but if they want to, this is not the time when we are saying only one bystander. What the hell? Let there be three. It's important for the woman to have the husband, the son, and the daughter with them. And in the context of dying people, if disease is incurable, futile and inappropriate artificial life support measures cause physical, psychological, and social suffering both to the patient and to the family. This is certainly not the ideal way to die. It may be the most expensive way to die, but this is not the ideal way to die. Palliative care, instead of this intensive care, is a humane alternative in incurable disease. I am not saying about salvageable patients. I am not talking about curable illnesses. Your patient, young man with COVID-19, may get well after ventilation and he needs it. The patient with a multiple rib injury needs to go on a ventilator for 5 days and he will walk out of the hospital. So certainly intensive care has its role, but not for somebody who is dying. And if you stop the ventilator, will that be euthanasia? It is not. We are not trying to kill the person. What are we doing? We are allowing natural death. And Supreme Court judgment says in 2008, they said, you can withhold or withdraw artificial life support and allow a natural death to happen. They have also put in a lot of procedures which are difficult, but this is the decision. So what will you do? Some of you must be intensive care nurses. If your doctors and nurses get together and decide on a plan of action, this is what I would like to happen. The patient may want more time. The family want more time. Continue whatever you are doing. Do not escalate treatment, but continue whatever you are doing. And if the family says, okay, BiPAP is okay, don't intubate him. Or they may say, okay, no artificial ventilation, but continue feeding him. You may accept it. Avoid, don't bring in the money aspect. Don't make the family feel guilty. And one final word, ladies and gentlemen. When you are thinking of withdrawing a ventilator or stopping any particular medication, never say there is nothing more to be done. Hey, that's not true. There's no situation where nothing more can be done. Holding a hand, making the person comfortable, wiping a tear, they are all important. For a family of a patient, it's very difficult to hear somebody say that nothing more can be done. That is not true either. You may say, though we will not continue the antibiotics, we will continue to care for him to keep him as comfortable as possible. That would be your message. I will stop there and take any questions now. We have just about 11 minutes for questions and answers. Everybody, please think. Questions are welcome, preferably in voice, but if you want to put it upon the chat box, that's also fine. Raju Seno, where is Magunda? Where are you from?
Raju Sena sister? I
Raju
think so.
Seno can say.
Sir, actually, Magunda is in Assam, sir.
Okay. It's okay. Diana came out with the same thing. Hello, Rasam. Okay, thanks. So now time for discussion.
Good afternoon, sir.
Hi. Who is
Hello, sir.
speaking?
I'm Jessie.
Jessie.
Yeah, sir. I mean, like we said, no, at the end of the life, like the patient is on ventilator and some support, but we know it's very. I mean, they are just continuing with that. So how we can explain? I mean, without their consent, can we do stop the things step by step or?
Jessie, the best thing would have been if you know that it's a person with advanced cancer, not to put him on the ventilator. In which case, what will happen is you will tell the family, say his condition is very bad, but he is gradually deteriorating. We want to do everything to keep him comfortable. That's all you need to say. We will do our best. If you want to come and stay with him for longer time, you are most welcome to. This is the time to be with him. That's what I will say. I will not offer him a ventilator. Why should I? That's not good care. But suppose, as Jesse says, he is already on a ventilator. Now it's difficult. So what I'll do is I'll find out who are the decision makers. 2 sons and 1 daughter. Okay. Can you all come together? No. My brother is in, one brother is in, Joby is in Kuwait. So let us say one in a Gulf country and one is in USA. Now this makes it even more difficult. Okay, can we all get together on a WhatsApp call? Is that possible? Investing that time is very important, Jesse. Very often I know hospitals don't do it, but I would consider that very important. If not, okay, one son or daughter is available, talk to them. This is a state of affairs. We were trying everything, but now his condition is deteriorating. I really do not think continuing that ventilator is useful. In fact, it may be causing him more suffering. This you cannot do by yourself, Jesse. The whole team has to sit together and decide this. The doctor, the nurse, everybody has to be on the same page. And they will say, but what will happen to my father if you stop the machine? And we will continue to give him palliative care. That means if he is breathless, we will treat his breathlessness. With the tube outside, maybe he'll be more comfortable. But if he is in pain, we'll treat the pain. You will be able to, we'll see if he is able to talk. If not, if he is unconscious, we'll continue to do everything to keep him comfortable. I can't take a decision. I'll ask my brother. Give them time. Continue whatever you are doing. Don't put on something more. But continue what you are doing and wait for their decision. People need time. People may take 1 or 2 or 3 days to take a decision. We have to go along with that.
Thank you, sir.
Welcome. As no questions are coming up and as we have time, I am going to bring up something. Arun said there are 30 odd people here. I'm making a guess that at least 10 people amongst you, 1/3 of you, would have gone through the experience of losing a loved one in your own family. As I said, it may be a grandparent, uncle, aunt, parent, anybody. And some of what I said would have been painful for you. Seeing that we have 5 minutes more, would anybody like to share a personal experience or bring up a question? Or it may not be a family in your own family. It may be your experience as a nurse with a patient, similar situation. Anybody wants to share an experience like that? Harishankar on chat box says, end of life care is planning for every patient, but in the last minutes, the patients discuss some things to the family. They are not expressed due to physical effects. Is there any other plans to receive information? I don't know, Harishankar, I didn't quite understand. If the patient is unable to explain towards the end of life, what do you do? That's a bad situation. What should be the solution? Could it have been prevented? Unfortunately, the problem is that we do not discuss prognosis early. We start this discussion only at the last minute. Only when the patient starts gasping, then you start these conversations. That's not the best thing. If the patient should and family should be aware, if they want to be aware, they should be aware of the prognosis, what's likely to happen. So ideally it's early. But if that is not happening, if it is towards the end, the patient is unable to speak, maybe that is a very difficult time, and all that you can give then is to continue lavish your compassion and affection on him, saying that is before turning an apparently unconscious person, still talk to them. Uncle, we are going to turn you. Auntie, are you comfortable? Even if you do not get an answer, and say that we are doing everything to help you, keep you comfortable. That's the best you can do. Sunil, are you here?
Yes, sir. Sir is here.
Yes, sir.
Sunil, thank you for coming and taking over. I have to join another meeting in another 2 minutes. So will you take over and conduct the case discussion? Thank you very much for agreeing to do this. Bye-bye, everybody.
Thank you,
Give
sir.
me a bye-bye smile, please. Okay, thank you.
Okay, thank you, sir.
Thank you, sir.
Bye, Ramaji.
Sorry, sir.
So, good evening. I am Dr. Sunil Kumar. I am the Additional Director of Trivandrum Institute of Palliative Sciences. I think I am meeting you for the first time. As Sheba is not available, I will be there to facilitate this patient story discussion. So, I don't. Can you share the patient story for discussion today?
Okay, Sister Diana.
Yes, sir.
Okay, can we start the case presentation? Okay, is
Okay,
it visible?
sure.
Is it visible?
Yes, yes,
Okay.
sir.
Okay, you can start.
Good afternoon, sir. Good afternoon to all. Today I'll be doing the case presentation. My name is Diana Chore, designation nursing officer, organization affliction Makunda Christian Hospital, Karimganj, Assam. My patient is a male. He is 64 years old. Diagnosis is perforation of peritonitis under malignancy inquiry, known case of COPD and alcohol dependence. Presenting complaints. Patient came with complaint of abdomen pain into 1 month, increased since 1 day, cramping pain diffuse all over abdomen with radiation to back and dyspnea. History of illness, abdomen pain since 1 month, fever on and off, decreased appetite, and patient is alcohol dependent for the past 10 to 12 years. On examination, pulse is 110 beats per minute, BP 100 by 70 mm of Hg, SpO2 95%, temperature 100.4 degree Fahrenheit, RBS 124 mg per dl, CNS oriented to place but not oriented to time and person, and it's fluctuating. Orientation is fluctuating, tremors present, and patient is agitated. Treatment and significant investigations. Biopsy sent, ECG, chest X-ray, X-ray, and X-ray abdomen erect. CBC hemoglobin was low, 6 gram per dl. And other blood investigations were also done. Treatment underwent emergency laparotomy, 1 pint blood transfuse. Patient is on catheterization on NG dependent NPO on IV fluids. Psychosocial aspects. Patient is 65 years old male. He is married with 4 children. Patient is unable to see from left eye since birth. He is a farmer by profession. Eldest daughter is married, and second and third children are both male. Patient has these 3 children. Older one is married and lives separately, and youngest son is with the parents, unmarried. He is a farmer. They are from Hindu religious background. Medications: injection PCM 900 mg IV Q8 early, injection tramadol 75 mg IM Q8 early, injection pantoprazole 40 mg IV BD, injection perinom 10 mg IV BD, syrup Casial 15 mg TDS, injection deripylene 1 gram IV Q8 early, injection tranexamic 1 gram Q8 early, injection ceftriaxone 1 gram IV BD. That Amlong 5 mg NGOD, nebulization with ipravin Q2 early, injection haloperidol 2.5 mg stat and PRN, injection lorazepam 2 mg IV TID to avoid it drowsy. The main concern is delirium and agitation, patient and family's acceptance of malignancy, basic care at home, financial issues with the hospital bills. Summary: a 64-year-old male came with presenting complaint of abdominal pain into 1 month, increased since 1 day, perforation of peritonitis and malignancy suspect. A patient underwent emergency laparotomy. Patient is also a known case of COPD and alcohol dependence for the past 10 to 12 years. Patient was delirious. Discussion points: how to help the family accept and face the patient's condition. Patient's wife kept requesting us to help her husband even after explaining the prognosis. It was hard for her to accept it. Is it important or needed to inform the patient about his prognosis because he is delirious and is not oriented most of the time? How can I help my patient receive good care at home, that is pain control, nutrition, hygiene after discharge? How to help the patient deal with his delirium and restlessness at home? Okay, thank you.
Thank you, Diana. So after laparotomy, was it confirmed as malignancy?
It was not confirmed, it was sent, and the report is pending, but his condition is not good. So we are
so-
treating him.
Yeah.
We are treating him as palliative care.
Okay. So the operated surgeon, what's his opinion? Is it malignancy or something else?
His opinion is malignancy, sir.
Okay. So we have a 64-year-old man who is having perforation, and probably because of perforation, he has peritonitis, and he is known to have COPD. Now he is delirious and was and catheterized and is receiving multiple medications. So how can we help the family to accept the patient's condition? Patient's actually patient's wife is not accepting with the diagnosis and prognosis of the patient. What can we do for that? Anybody? Anybody? Asmita, are you speaking? You are muted. Nobody has. Okay. Dr. Parvati says counseling the family members and patients. Yes. Counseling. Okay. I will give you another situation. Suppose it's one of your close friends or relative. How will you feel when you are in this situation? Yes, it was so sudden. I think you have to give the patient family some time to accept. Denial will be there. Okay. So this was not. It was not expected, isn't it? This patient went to the hospital with abdominal pain, and from there they are telling that it is malignancy and the prognosis is very poor. So it is not his wife's problem. Even if we face the situation, we will not be able to accept that at the first instance. So all of you know that in any serious condition, the patient go through some emotional reaction. What are those emotional emotions? It is dabda. What is dabda? D for denial, A for anger, B for bargaining, and D for depression, and A for acceptance. It is DAB, DA, dabda. So we will we cannot accept the fact immediately. This is same with us also. It's not the problem of wife's fault. So what we have to do is just make her aware, and if she is not accepting, it is okay. But you have communicated the problem to the wife, and maybe after some time, and actually you may not have proper rapport to the with the patient or his wife or his relatives. So it will take some time to get accepted. Till that time, it's our duty to be with her and understand her and listen to her. She might want to ask you many questions. Why did this happen? And things like that. So it will take time to accept. Okay. So anybody has any more opinion on that? You can unmute and speak. Okay. Is it important to inform the patient about his prognosis because he is delirious and is not oriented? So anybody can answer this question. So what happens in delirium? Will the patient be normal in any time during delirious episode? I can see some one no and one yes, sometime oriental. It's fluctuating. Yeah, what we have to understand is that in delirium, patient can have some normal periods in which the patient is fully conscious and oriented. But as somebody told, it keeps fluctuating. So sometimes maybe one of you go and see the patient, and at that moment, patient may not recognize you, and you may and she may ask you, patient may ask you, who are you, etc. But maybe after some time, maybe after 5 minutes, you may again go, and at that time, patient may actually will be fully oriented and conscious. So there are some moments in which patient is fully conscious. But I think it may not be a good time to speak to the patient to talk about communicating bad news and prognosis. So maybe it is better to wait till the patient gain full consciousness, and when the delirium episode is over, then you may talk to the patient and communicate the bad news. How can I help my patient receive good care at home? That is pain control, nutrition, hygiene after discharge. Okay, I see that somebody has answered it in chat. Needs opioid steps consult with doctor. I didn't get home visits. Yeah, patient teaching. Okay. How can we give good pain control? Family education regarding care. Yeah, that's important. So, Sister Diana, how was his pain? Is it mild, moderate,
Yes,
or
yes,
severe?
yes, sir.
Is it a mild pain, moderate pain, or severe pain?
Oh, sometimes he have severe pain, but most of the time it's moderate for now.
Okay. Which step of WHO analgesic ladder can we use to treat moderate pain? Yeah. Second step. So what opioid will you use? So maybe tramadol you can use, which is used to treat mild to moderate pain. Yeah. Or even you can use low dose morphine. That's also possible. Uh, uh, Use a low dose morphine, maybe less than 30 milligram per day is considered as second step of ladder. Okay. So this patient received injection tramadol, 75 milligram BD, and it's through IM. So what is the most common side effect of IM route? Anybody? Discomfort? Okay. Pain. Yeah, that's it. Pain is the most common problem with IM injection. And if you ask your children to come for vaccination, there will be some resistance. They will cry and even hit you. So it is because of the fear of producing pain. So patients probably in palliative care, we never give IM, and there may be a virus situation. Otherwise, 99.9% of instances, we give either intravenous or subcutaneous injections. Tramadol can be given subcutaneously also or intravenously, which is less painful. So we should give either IV or subcutaneous tramadol. And when this patient go home, you can give oral morphine or tramadol. And there will be surgical wound which you have to teach the caregiver how to take care of, which is also very important. Otherwise, there will be wound infection. So, educate the wife how to take care of the wound and how to clean the wound after passing motion, etc. How to help the patient deal with his delirium and restlessness at home. What can we do? Okay, Asmita says orientation. Send him with his not complete. Haloperidol tablet. Okay. Parvati says haloperidol for sedation. Okay. So, what are the causes of delirium in this patient? Can anybody think of any causes? I don't. Can you show me the slides from first onwards? Yeah. 1 minute. 1 minute. Yeah. Okay. Go on. Okay. Next. Okay. Next. 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 Okay, next. Okay, next. Okay. Next. Okay. So I can see some answers in the chat. So people say alcohol, fever, alcohol surgery, new environment, electrolyte, different fever, resistance, alcohol dependence. So all these are possible factors contributing to delirium. So first of all, this patient was alcohol dependent. So when this patient is in hospital, he has not taken alcohol for the past few days, and that itself will cause alcohol withdrawal. So that will be a cause for delirium. And another cause might be, as all of you told, it's infection, because the patient has fever and peritonitis. So that's another cause. And a new environment and the ICU as such is another cause. Uh, then electrolyte imbalance. This patient is getting potassium chloride, so I don't know whether there are any more electrolyte imbalances. So electrolyte imbalance is another cause. Um, and the nasogastric tube and Foley's catheter is another cause of delirium. Yeah. And even the tramadol opioids. So all these might be the contributing factors. So we have to see which are the contributing factors to delirium and correct all those if possible. And then non-pharmacological management of delirium has to be instituted. Like what are the non-pharmacological management of delirium?
Orienting the
Yeah.
patient periodically.
Yeah. Yeah, orient the patient in time, place, and person. So maybe you can what can you do to orient the patient?
We can keep the windows and all open so that he can see it outside, and we are doing that.
Yeah.
And also talk to the patient and tell him like, yeah, you are here in the place, and orient them to the people beside them.
Yeah.
And also orient the timing.
Yeah, and you can actually keep a calendar inside the room and ask the patient which is the date today, and tell him this is the date, this is the day, and this is the time now. And at night, the lights should be off, and in the daytime, it should be well lit, so that the patient will have some orientation. And if the patient is using some glass or hearing aids, the patient should wear it. And if he has the habit of wearing a watch, then we should allow him to do that. And probably he will be using mobile phones. We should allow him to use mobile phones. And some albums from his home, and ask him what was the occasion during which this photo was taken, and you can ask him to identify the people in that photo. So all this will be helping the patient to orient to the time, place, and person. And you can actually look for whether the nasogastric tube is needed now. If not needed, please remove the nasogastric tube as well as Foley's catheter, and treating the infection. So all this has to be done together. And as symptomatic treatment, we should give haloperidol. And at the same time, you have to also communicate with the wife and tell her that this is not madness. And this delirium is short lasting, and it will be over once we treat the contributing factors. Uh, and tell her how to identify delirium. And if it happens at home, uh, you can ask her how to treat symptomatically. You can also tell her about the non-pharmacological management, so that delirium will not recur at home. So prevention is better than cure. So you can actually educate the wife regarding the same.
Okay, sir. Thank you. And sir,
Yeah.
in the another problem, the concern was financial, because they are very poor. But I didn't bring in discussion point because the treating doctor, the surgeon has decided that they will pay as much as they can. The rest they will give charity.
Okay. Yeah, that's an important factor for patients in India. And do you have a connection with NGO or something for financial assistance for these type of patients?
Usually we don't. The hospital used to pay by the hospital itself gives charity for the poor.
Oh,
Uh,
okay. Anything else you want to ask?
no, sir. Thank you so much.
Uh, so we have to actually, we will not be able to make anybody to accept any diagnosis. It will be a slower process. Some people will be a little bit faster, but others will be slower to accept, because they will go through a lot of emotions. And maybe at last, maybe after, we don't know, we can't tell what would be the time period in which they will accept the diagnosis or prognosis. It depends on personality. And uh, as the patient is in delirium, and as he has undergone surgery, once the delirium resolves, then we can talk to the patient and inform him about his problems, like communicating bad news regarding malignancy. Uh, and actually, the wife need to be taught regarding how to take care of the patient at his home. And you can also tell her about the non-pharmacological management of delirium, and give him pain medications like low dose morphine or tramadol, and if possible, remove Weil's tube and Foley's catheter, which all are the contributing factors for delirium. So,
Yes, sir.
Arun, can you unshare the screen? Okay, I don't. As Lakshmi told, this is the last session of this FCPN.
Yes, sir. Yes, sir. This is the last session for this program.
Okay, so this is our last session. So I would like feedback from all of you, and please speak a few sentences to tell us regarding what are the advantages, and what has to be actually improved. What are the good things? Please unmute yourself and speak.
Hello, sir. Yeah, I just wanted to say, like, we have learned so much through this course, and we are so thankful. And one of the things that I would like to advise is to continue to let the students participate, which makes us even more attentive. Yeah, this should continue. Yeah, thank you so much.
Thank you, Diana.
Hello.
Yeah.
Yeah, hi, sir. Very good evening.
Hari-
Actually, in
Shankar,
this
yeah.
course, sir, actually in this course, we have learned so many things, especially in communication part. Dr. Vijay Raghavan, sir, we learn a new issues, how to solve communication settings, each and everything. He explained, and the psychological issues.
You are not very audible, Harishankar.
So, sorry, sir, some network issue. So actually, this FCPN program is very because I'm also as a palliative nurse Dr. Trust Hospitals. But this course is through online. It means there is a less effective for a clinical exposure. Along with these classes, is there any clinical exposure? It is very effective, in my point of view, sir.
Yeah, I agree with you, Harishankar. And are you working in palliative care setting?
Yes, sir. Right now I'm working in palliative nurse, Tata Cancer Hospital.
Yeah. So all of you, if possible, I think you should go and visit your nearest palliative care center so that you can get some experience with patients.
Yes, sir. Previously, I am also trained in MNJ Oncology Hospital of Hyderabad.
Oh, okay, okay.
Right now I'm working there also, sir. But it's a very nice program. It's basics to we learn so many things in palliative care. But it is very effective, sir, because they teaching especially very experts. They tell different issues, sir. But in case it is offline mode with clinical experience, it is more effective. That's it, sir.
Yes, definitely. So actually, we have brought this program because of the COVID situation, and for the last 1.5 years, we were not able to do the on-site courses. We actually conduct on-site courses
Okay.
every 2 monthly, but unfortunately, because of this situation, we are unable to do that. So we are conducting more online programs so that there are many people who actually wanted to come and do the course, but they were unable to come because of many reasons, even if there is no COVID. So I think for those people, it has benefited because they can do the course without coming here. But as Harishankar told, the first-hand experience with patients is also important. Thank you, Harishankar.
Thank you so much, sir.
Yeah, good evening, sir. The entire course was very good. Actually, I don't have a palliative background. Still, I could learn a lot. So that was indeed, it was a very good program. And only regarding the case presentations, actually, those who are not from that areas, no, not from the palliative, we don't get that all the cases which the with the topics which we are discussing. So,
Yeah, I understand that
yeah.
difficulty. Yeah.
Yeah, and then I think it's just a suggestion for if any classic cases of that type is there, you can share with the participant, and that participant not in the palliative care can present that case, and that will be I mean, the participants will be more involved in that. I believe so.
Yeah, yeah. Okay, thank you.
Yeah.
This is.
Thank you. Otherwise, it was very good. Thank you
Where
so
are you
much.
from?
I am from Delhi, actually.
Okay.
Yeah. Thank
Yeah.
you. So if any time can we come to the tips where it's actually in Trivandrum or
It's in Trivandrum. It's in Trivandrum.
yeah.
Actually, as of now, we don't have on-site training, but
No,
once we start on-site training program, you can come and visit Palim India. Actually, all of you, please send us a mail when you want to come so that we can see whether you can be accommodated during that time
Yeah.
which you prefer.
okay, yeah, fine. Thank you. Yeah.
Anybody else?
Any feedback, any sharing?
I can see a lot of
Any
chat
participants?
comments in the chat box. Smita? Dikshita?
Anyone from Akshnita, Dishita, those who are from Nepal?
Yes, yes. So on behalf of Nepal, I would like to speak. So we are all 5 members and we are work colleagues working in the same hospital. So I would like to talk on behalf of all of us. So we are really very thankful for the wonderful opportunity to exchange the ideas between among the countries, which is one of the best point of this Palim India, because we are not only from one nation, we are all from different countries, and we have our own practices, we have our own knowledge, and we all got this opportunity to exchange our ideas in terms of our knowledge and skills, and that is the very, very good point about this session. And also it was a great learning experience, and we could learn a lot and much more from the case presentations, and we got an opportunity to share our ideas also. So we all are new in this field, and by learning all this session, we could actually realize that it's just the beginning of our study in this area, and we have a lot of more things to learn and to see, to observe, and to share. So thank you so much.
Thank you, Dikshita.
Thank you, Dikshita.
Which setting are you working?
So we are working from palliative, but we are new in this area. So it's been only 4 months we are working in this field.
Okay. Thank you.
Or any feedback? Sister Faustina, are you there?
Yes, I'm here.
Okay, thank you, sister.
So Arun, please take care of them, because most of us here will want to join the call, but it's just that we can't pay in dollars. Neither can we. Here in Ghana, the process to your end is not done. So if you can really get a dollar account, it will make it easier for most of my colleagues to join, because I have to pay my fees through Dubai. So if someone don't know anybody there, it will be very difficult for them to pay the fee.
I don't.
Yes, sir.
Yeah. You know the problem?
Hello.
Yeah. Is there a problem with fee? She's talking about the fee.
Sir, I think the problem with the transfer of money, sir, she's from Ghana.
Yeah.
She's an international patient. The international.
Yeah. I understand. Okay. And Sister Jessie was asking whether there will be any volunteer training program. I think it is happening every 2 months. Saran, you can give her name to Rajagopal, Babu.
Okay,
So
Sister
that,
Jessie. I will share the details with you. We have alternate program in English and Malayalam. Which one you are interested? But it's a 1 week program, 5 days continuous program at evening sessions only, 5 to 7 p.m. I will share the details. If anyone interested from this group, they can join this program, this volunteer training program. And more than that, we have one more 1 week program that is called the Pali Code Echo program. That's also free training program. If anyone interested, they can join. I will share the details in WhatsApp group.
Palikav training program is on what can we do for patients with COVID from the palliative care. So it's an integration of palliative care into that COVID issue.
Yes, sir. In context of COVID-19. I think in June first week we have one Palicode Echo sessions. Anyway, I will share the registration details and it is a free training course, 5 days. If those who are interested, they can join. Sir, any feedback from anyone?
I have one feedback regarding the assignment.
Yes. You can.
Like in my opinion, I thought it would be better to have more assignments in between in less gap period. And also, a timely checking of the scorings also, because we have submitted 3 of our assignments and none of them have been checked, I guess. That's why.
Okay, Dikshita, we will get back to you. Yeah, that we will consider your suggestion. Thank you.
Okay, Sister Dishita, please check once your mail. I think the assignment 1 and 2 are corrected. Just I want to check it, recheck it today. Okay.
Okay, so if there are no more comments, I think we can close this session. And thank you for joining us. And it was our privilege to have you with us for this 18-19 sessions. So thank you. We will continue to be in touch. And if you need any help, please let us know. I don't.
Okay. Thank you, Sunil sir.